Ladies and gentlemen, you are welcome to this session, which is one of the sessions on the last day. And indeed, we saved the best for the last day. Our topic today, as you already know, concerns the field of impact science for Africa, and it resonates very well with the overall plan for the week at CUGH, because impact was an issue that was running through the week. We are two co-facilitators for this session. Myself, Nelson Sohan-Kambo from Makerere University College of Health Sciences, and colleague Joseph Collas from University of Michigan. Maybe let me ask my co-facilitator to first introduce himself in 2 sentences or so, and then we'll continue.
Great to see everyone here on such an important topic. I know this has come up in a number of our conversations, but as Nelson mentioned, I am based at the center or at the University of Michigan in the US. I run the Center for Global Health Equity, which brings together disciplines from across our universities to co-design for impact in low-income settings. So great to be facilitating here with Nelson. Nelson, back to you.
Thank you very much. Myself, as I mentioned, Nelson Sohan-Kambo, I'm a professor emeritus at Makerere University in Uganda. My background is in internal medicine. Let me try to define the task for us to discuss in this 3-hour session. But before I do that, I welcome all our participants who have committed time to join this meeting today. And please, if you can, as much as possible, remain online, participating in the discussions for the entire 3 hours. I think this is going to be a very exciting session. It's a difficult one, but it will be very exciting, I think. So what is our task? What brings us together today is to try and step back. We have all used the word impact or the concept impact in our official work, professional work. We use the word impact very, very often. But we thought we should step back today and try to interrogate this one word. Interrogate this one word, impact, or the concept of impact. What does it mean to you? How do you use it in your day-to-day professional work and so on? And therefore, the expectations at the end is that we might come up with an impact science construct to inform AFREhealth's work moving forward. This session has been organized by AFREhealth. AFREhealth is a Pan-African consortium which brings together any educational institution or in health on the continent. They are free. Any institution is free to become a member. And as such, also, we bring in various professions. It is an interprofessional organization. And hence, it brings across a mix of people of different backgrounds. And as you might expect, because the people are different backgrounds, they may be looking at impact very differently, and they use the word in different ways. And so, but as AFREhealth, a consortium, we thought we should come together and be able to have a meaningful conversation today, and that conversation may not end today. We plan to carry it on, but give a start to that at least. We know that there's a lot of discussion about impact across the world. In fact, the United Kingdom has been discussing impact a lot around the research impact assessment of universities, and more recently, the research impact framework evaluation. I also learned very recently that University of Michigan and the Global Health Center, which Joe Collas leads, has actually picked up this issue of impact as one of their priority areas to think about and move forward. And therefore, Joe Collas becomes a resourceful co-facilitator in these discussions. With that introduction, let me call upon Joe Collas to actually try and summarize in his thoughts, why is this session very important? What is its significance?
Great, thank you, Nelson. I'm just going to pull up a few slides here. I just have a handful of them. First of all, one of the questions that's going to be important for the panel and all of us, should we be calling this a science? Is there such a thing as impact science? Is it a field that we should try and take ownership for? You may recall some of the same questions came out when people were thinking about the field of implementation science. But impact appears, as you heard Nelson say, it appears to be an overutilized term for those pursuing global health research, and it really lacks a definition. You may recall in our field when finally, we felt it was important that global health be defined. Well, should impact be defined, or is it okay that it's just used in a loose, unspecific way? And the specific question that we hope to be able to answer at the end of this webinar, would we benefit from trying to define, or at least be more mindful of the need to provide an explanation when we use the term? I think all of us are, at least for me, when somebody says impact, I immediately say, well, what do you mean? So that's what we're hoping to get out of this conversation. If we can, why I think this is a particularly important question is that it harkens back to something I'm hearing more and more about the role of universities in society. Those of us who are in universities think we're pretty darn important to society. But so often, the people that we're called on to serve think that we live in ivory towers. We sit and we write our papers. We have a certain language that we talk to each other in. We get promoted. We get our grants. We're pretty incestuous. Whereas a lot of people outside of academia will say, well, how's their work connected to the common good? We say to ourselves, well, it's obvious. Of course we're impactful. But I think a lot of the people that we want to be relevant to aren't quite sure how to interpret what we're talking about. I've run into this quite a bit because so much of our center is funded by philanthropy. And I know for a lot of our philanthropic donors, they wanted to know something else beyond whether we were able to leverage up pilot money for the next grant. So I think it's a particularly important question for the Academy and at least something that we should try and clarify. I don't know about you, but I'll often hear people use the word impact synonymous with quite a few other terms that at least for me, don't connect with impact. So, for example, I'll often hear people talk about impact as activities or outputs. Of course, we had impact because this is what was done. As a result of this initiative, as a result of that grant, this is what we did. And they'll call that impact. Or they'll use impact instead of the term results or outcomes, consequences of what was done. For me, results or outcomes, examples would be, the satisfaction surveys. Do people like what happened? Is there evidence that something is people are smarter or more knowledgeable, or can people do things differently? So for me, at least that is a different sense of impact. And I think of those as activities or outputs, results or outcomes. So, for me, getting closer to an impact is something that is obviously connected to a specific audience. And especially those of us very passionate about AFREhealth, a lot of times impact it can be very defined by NIH. That's who funds AFREhealth. And what does NIH want to see? And if they see it, that must be impactful. So, but I do think we have the opportunity to talk about impact in a more meaningful way, particularly outside of academia. Because I think for those of us who are always on the look for funding, I think the social entrepreneurs and I think philanthropy want to know what's happening to people. Not what is happening to our internal metrics. Of course, we need to talk about those internal metrics. That's the coin of the realm. But maybe to give you a little bit of a sense of this too, is just to be mindful that a lot of the research, we get hung up trying to cross the valley of death because things don't translate, and it's tough to show the ultimate goal of maybe somebody living longer or people lived longer. That's tough. There's a lot of steps along the way, but I think that we do have opportunities to help people to see that. I think many of us watched the NIH kind of change how they were thinking about translation when they came up with the T metrics. What kind of T research is this in translation? Is it basic and preclinical, all the way up to something that affects healthcare delivery and policy? So I offer this because this is kind of that example of a rubric. Might we think or try and wrestle with a rubric for impact? And just so you understand my starting place, I don't know that we need to do things differently, but I do think it would help if we talked about things differently so that people understood the context of what we're working on and seeing how it connects to people. Let me give you an example. I think this is my last slide before we close. Could we develop some kind of impact evidence hierarchy? Again, this is an example. This is not what we're doing. But for me, I think impact is people living longer or better. Getting first order evidence of that can be a real reach. It can take a lot of time. And as you know, there's all kinds of conflicting variables and attribution. Second order, maybe more people are with factors influence or associated with first order. Third order, policies that are enacted for financing and things like that. Again, I don't necessarily think, I do not think that we need to change what we're doing in terms of research, but I do think we would benefit if our stakeholders understood how this could connect. What's the line of sight to helping people? So this is just one example, but I think I will end there, Nelson, and turn it back to you, because I'm looking forward to getting some perspectives from our panel.
Thank you very much, Joe, for those introductory remarks. I think they give some insights and make people begin to think about this topic of ours today. Let me say at this point in time, please, members in the audience, if you have a comment or question, feel free to post it in the chat box, and we might have time to get back to that, but please don't lose the opportunity to do so. With those comments, it takes us to listen to our very eminent speakers that we have today. Highly selected purposefully, and each one is going to give us a 3-minute talk. This is rapid fire, and they will all give their talks up to the end, not interrupted with questions or comments. And after they have talked, we will have a panel discussion. Those same speakers will be then discussing in a panel. The very first speaker is Professor Musa Makerere. He's a professor of public health and deputy vice chancellor for research and innovation at the University of KwaZulu-Natal in South Africa. Over to you, Musa.
Thank you, Nelson. Thank you, Joe. Greetings.
Sorry, and Joe callers, please be prepared after these presentations to take on the facilitation of the panel discussion. Sorry, Musa, go ahead.
No problem. I want to pick up on where Joe left off. Indeed, I think I'm also preoccupied with the question of impact at the moment. We have learned through our science and academic career, it's important to get grants so that you can have well-funded research, because well-funded research, you can be able to produce good science. And good science can lead to high impact in terms of science. Scientific impact is one form of impact. And most of us, of course, we are preoccupied with that for reasons that have already been stated. But sometimes we go further. We want to move beyond that scientific impact after publishing in a high impact journal, having done well-funded research, and you go and influence policy. In 2005, there was a big outbreak of drug-resistant tuberculosis in South Africa. And we went back to look at that process from the time when there was that problem, and the paper was published quickly, early, beginning of 2006, to how long it took for change to happen. The policy to actually deal with that problem was launched 5 years later in 2011. We studied the whole process, and we realized that it could not have been done any shorter than that. Now, that is just the policy. It is not necessarily the impact of the interventions that were put in place. Now, for this reason, I've been, of course, concerned with the 17-year odyssey. The fact that once you've got a publication, it takes 17 years for only 14% of research to be translated into practice. Once you've got policy, you still have to translate into that into practice. In South Africa, we've got a major problem of policy implementation gap. And because of that, for me, I'm seeing that the benefit do not necessarily accrue for the intended beneficiary. So I went also to look at other studies. If you look at cancer control studies, a paper by Khan in 2021 says that for HPV vaccination, it took 14 years from the time when the evidence was put out to the time when they had, on average, in terms of policies and interventions really rolling out. And that is not talking about high levels of coverage, just making the vaccines available for various reasons. And from COVID also, we learned that it's one thing to develop a vaccine. It's another thing to put it into a program. It's another thing to get into the arms. For me, impact is when it gets into the arms and we begin to see lives saved and people have prosperous lives because of the investments in their health. Now, all of this depends on a whole value chain of diffusion of innovation that we often don't engage with as scientists. And for me, I have been looking for the solutions, and I'm encouraged by the movement around active dissemination and implementation as a way of closing that gap. Because with active dissemination and implementation, that 80% of research can be translated within a space of 3 years. 3 years is not great if you compare for a problem like COVID, but it solves many of our problems. If we were able to achieve high coverage for HPV and reduce cervical cancer in 3 years, we would have saved a lot of lives. There is a cost to the delay, and we've got to talk about that cost of delaying successful implementation and population benefit with interventions. So I'm hoping that this discussion can help us to start moving in that direction in the way that we understand impact. For me, really, it comes down to the people that are intended benefiting from the innovations that we are able to produce, and us putting resources, effort into active dissemination and implementation and not stopping at the scientific impact. Thank you. I'll stop there.
Thank you very much, Mosa. Let's move on to the next presenter, who is Dr. Marie Glorious Ngabire. She is the director, regional director of IDRC in West Africa and Central Africa, IDRC International Development Research Center. Marie, the floor is yours.
Thank you very much, Professor. Thanks for inviting us to speak to this important topic, and also among our really great speakers. So indeed, I'll be, of course, speaking from the perspective of IDRC, which is an organization that supports research for development. And for us, we often see research impact sometimes very different than the traditional implementation of development projects or programs. So I hope then with that perspective, we can really contribute to advancing this discussion on impact of research. So I will start by saying that the impact of research is generally characterized as a long-term positive change. And I think that already has been mentioned by the previous speakers. However, the long-term impact in terms of changing policies, in terms of product development or publications, was mentioned, system strengthening and similar also trajectories are quite important. We don't dismiss that, and that's where we want to get broader impact. However, we are also feeling as a research community that, and we're learning at the same time, that it's really equally important and significant to be able to capture the impact of doing research in itself. So we see really research as an intervention in itself. So who's engaged in the research project? How are they engaged? Who is part of the design? Whose voices are elevated? And who are we missing? Who are not listening to? So all those aspects are really critical in terms of thinking about research for development in particular, and its impact. So the legitimacy of research can be a key driver of long-term results, as it's been again mentioned in terms of policy change or new vaccines or publication, but it is also a tremendous force for good on its own. So this is really part of what we currently capture from our Research Quality Plus approach. And we have today the great pleasure to have some of the leaders in this area, Rob McLean, my colleague, who I'm sure will be able to expand on that if needed during the panel that will follow. So this framework that we've been really using identifies and allows us to measure dimensions of quality that really uncover those non-traditional benefits of science and research. And as such, at IDRC, we have developed also various approaches and tools for measuring those underpinning elements that generate research impact. And that has been done alongside stories and counts of typical or traditional impact. So for example, we've developed what we call the science of scaling, so scaling science framework, that includes 4 guiding principles to steer the effort toward impact from really the very beginning of a project or a program throughout its implementation. So those 4 guiding principles include justification. So it's important to understand why we're doing what we're doing. There are principles around optimal scale. We unfortunately often think that bigger is better, which is not the case. So what are the optimal scale we're talking about? The coordination, again, coming back on who is involved, how, and for what purpose, and also keeping that perspective of dynamic evaluation, where you keep learning, adjusting, and moving forward. So those principles have been really derived from a large retrospective study that we conducted with partners who are based in low and middle income countries, and they're identified as enablers of success. So for IDRC, they can facilitate evaluation and of course correction on the journey to longer term change, as they ensure our work is done in ways that are beneficial and impactful as it happens. So finally, by their very source, they can encourage work that is built in and for the global south. So finally, I want to say that I appreciate the title of the session very much. I think it's very important that we really tackle this topic. There are many mechanisms and tools we can take off the shelves, shared by management consultants that claim to capture and tell the story of impact with precision. But as a research organization, we know well that few complex ideas really hold simple solutions. So we argue for a field of open debate, which I think this session is a great testimony to that, a pluralism of approaches, a sharing of experience and co-development of a science of impact, and a strength of looking for local solutions to the ever-growing impact agenda in low and middle income countries, but also everywhere. This will be really the diversity of knowledge and culture existing across all regions. So let's work together to create that space where our experiences with impact can be shared and co-created. So maybe I will end by saying that as we'll continue the discussion, maybe we challenge the approach of universal solution and we start embracing pluriversality. So I'll stop here. Thank you very much for the opportunity. You may be on mute. Maybe.
Oh, sorry about that. Thank you very much, Marie, for those insightful discussions. Let's move on to another funder, Dr. Nosa Orobatum, from the Bill and Melinda Gates Foundation. He is a senior advisor, in Health Africa at the Bill Melinda Gates Foundation, where he previously served as Deputy Director for Maternal, Newborn, and Child Health. And before that, he worked in Geneva, WHO, and also at the Global Fund. He has advised ministries of health or ministries of health in Western Africa, Eastern Africa, Southern Africa. So he has seen it all happen here, how it happens on the continent. No, sir.
No, thank you very much, Nelson, and hello to everybody. Sometime around May 2016, the then Director General of Health Services at Uganda's Ministry of Health traveled to Sokoto State in northwestern Nigeria to meet with the governor to ask for assistance on how to address the problem of maternal mortality that's due to hemorrhage, which was one of the issues that she was tackling in her role in Uganda. And she took this trip on the basis of a publication that was of a journal that was published describing what happened in Sokoto in community-based distribution of misoprostol. And the governor asked her to go to the community and talk to the men and women and the village chiefs on how they were able to succeed in getting misoprostol accepted in a predominantly Islamic community, in a predominantly male-oriented society. And she came out with that solution, and she went back to Uganda. And now she's the Minister of Health, and she was able to introduce misoprostol as one of the interventions, you know, to drive the reduction of preventable maternal mortality in that context. Of course, misoprostol is an innovation that's been in place for years. There's been a lot of research that helped to create it and to make it available. So when I put all of this together and listening to some of the comments that was made earlier at the introduction by Professor Collins, for me, impact is a combination of the emergence of innovation. They could be qualitative, they could be quantitative, they could be scientific, but that these innovations have to have a goodness of fit with the problem or the issue at hand. That's the first consideration. And that the second, that these emergent innovations have to converge in place and timing, not just in time, in timing. And once they converge, this needs to happen in the geography affected, at scale, as quickly as possible, for as long as needed. I'll stop here.
Thank you. Thank you. We wanted to hear more. You stopped too early. But thank you. Let's move on to the NIH Forgotten Center, Peter Kilmans. Just to let our audience know, AFREhealth was launched 6 years ago in Nairobi. And we have been blessed since then that we got a grant from the NIH to support these early beginnings of AFREhealth. And here the question is, does the way AFREhealth see impact align with the way NIH sees impact? Let's hear from Peter Kilmans. Your thoughts about impact.
Thanks, Nelson, and greetings, everyone. I'm really delighted to be part of this distinguished panel in addressing this really important question. I think we're talking about using the word impact in at least a couple of different ways. And before I came to the NIH 8 years ago, I was more than 20 years with the CDC, the Centers for Disease Control, most of that time in Asia and Africa, and working on PEPFAR implementation, the President's Emergency Plan for AIDS Relief. And CDC has a nice logic model looking at inputs and activities and outcomes, and ultimately over the longer term, the impacts, the actual public health impacts of activities. And some of this discussion is capturing that view of impact, where we really want to see lives saved, illnesses, adverse health outcomes averted, those kinds of real public health impacts. And we can look more upstream at some things, such as numbers of people tested or improvements in health awareness. But it's important for those to have using those as kind of surrogate measures to really have a good evidence base that those ultimately do result in the kinds of health impacts that we're looking for. So taking off the CDC hat and putting on the NIH hat, where we're talking about the scientific impact and really at scientific research and publications and the citation rates of publications and that sense of scientific impact. And there's been some nice work by the Institute of Medicine, now the National Academies of Medicine, looking at the sort of stages or chronology of impact, starting with a publication, but then leading to things being picked up in the media, awards, new research programs being launched, that progression of scientific impact. And I think in that area, and it's true that some of the world looks at that as kind of an academic ivory tower exercise, but it's important as Homo sapiens that I think we value just learning more about ourselves, about biological systems. And the US spends billions of dollars to put people on the moon or take pictures of Pluto, which isn't directly benefiting anybody in the short term, but we think that's important. That kind of scientific progress is important. And years ago, someone was messing around with bacterial immunology and discovered the CRISPR system. And now we're getting FDA approval, which at the time, seemed like an interesting area. Kind of curious, but over time, we're now getting FDA approving use of CRISPR to treat sickle cell disease. So it's very much worth having the system of scientific impact, how often a paper gets cited in other subsequent publications, even if it looks like a kind of a ivory tower exercise and not necessarily directly leading to health outcomes, improved health outcomes in the short term. And we recognize that there's a lot of bias and a lack of equity in the scientific process, but it's still a valuable measure. We did an analysis a few years ago and saw that of all the publications that NIH has funded, those publications that have both US and non-US affiliated co-authors have a higher scientific impact or greater citation rate than those publications that have US authors only. So it's hard to directly relate that to improved health outcomes on the ground, but it is important to have those kinds of metrics to be able to assess how our science is being conducted and what the impact is in that sense. So those are just a few thoughts, and I'll stop there and look forward to hearing the others.
Thank you very much, Peter. I think I did this service to you. I didn't introduce you briefly, that you are the acting director of the FOGAT International Center and acting associate director for international research at the US National Institutes of Health. That was Peter Kilmax. Thank you. Let's go on to another Peter Singer. He's not from the US, he's from Canada. Peter Singer is a former special advisor to the Director General of WHO and a co-founder of the Grand Challenges Canada. And he, at the University of Toronto Joint Center for Bioethics, he was instrumental. He was one of the co-founders of that bioethics center. So, Peter Singer.
Thank you so much, Nelson. And let me just start by expressing my respect and appreciation to you for your 40, 50, 60, maybe 100 years of service to global health, Nelson. And I think everybody here very much appreciates that. Would also like to recognize the presence of my friend Keith Martin, the president of CUGH. And also a shout out to Joseph Savada, who's on. He's Slovakia's ambassador for global health and a member of WHO's executive board. He put a question in the chat for people. So I wanted to start there. Look, I think the question of impact, in a sense, is already solved by at least the governments of the world when they agreed on the SDGs. Because the SDGs have a very serious system of outcome measurement. And, to play off of what Joseph was saying, those are outcomes. They're incidents, they're maternal mortality. Those are things that affect humans. They're the long-term outcomes, which I think is the same as impact. Anything that affects a human, they're universal, they're across 17 goals. When you look at them in health and across the board, 15% across the board are on track. That's the problem. And when you look at them in health, you see, for example, from WHO's Data Hub at who.data.org, that a goal like UHC, universal health coverage, is going at about half the pace it needs to reach the 2030 targets. So the problem we have, the burning platform we have, is not how do you increase that by 10%, but how do you double it? And that's a particular type of problem. You won't get that from, another guideline on primary health care, but you will get it from looking at the how, the methods, data and delivery, innovation, digital, partnerships. These have already been mentioned. And I've written a little blog about that, arguing that to double the pace, we need to replace the SDGs with the GSDs. Now, to find out what GSD stands for, go to my blog at singerp.substack.com, subscribe for free, and I'll come back to that at the end of my remarks in about 1 minute. So the first point is impact measurement is there, and we have a political commitment for it, and it's the SDGs. The hard part is impact science. Namely, how do we as individuals and organizations actually influence the SDGs? I've already mentioned the methods, but let me just zero in on WHO's results framework, because I think it's very illustrative here. In terms of outcomes, WHO defines outcomes at 3 levels. Healthy life expectancy, which is the grandmother of all. That's the how long do you live and with what quality of life. The triple billion targets, which is taking 50 health-related SDG outcomes and clustering them into 3 things: healthier populations, which is like social determinants and climate; universal health coverage, which is the provision of health services; and health emergencies. And that's just taking the 50 and clustering. And then at the 3rd level, the SDGs themselves, the 50 or so individual out of 169 SDG outcomes. So that's how WHO measures impact and outcomes, shall we say. But then the question is, okay, well, how do you influence that? And there we've adopted a method of data and delivery, where you look in your own institution. It applies to WHO, but it applies to any multilateral, to any NGO, to any organization, to a university, to an institution. It says, okay, once you've picked what SDG outcome or outcomes you want to influence, how do you know you're influencing them? That's the output question. What is your contribution to that? And the method that has been developed has been to use delivery for impact, originally used by the UK government to measure whether that government was keeping its promises. First, you say, do we have an acceleration scenario? Do we know how much we need to increase, let's say, decrease maternal mortality? Secondly, have we allocated budget to that? Thirdly, have we selected the countries where you have the highest prevalence? Or in the case of a country, because this all starts with countries, country voice, country priority, countries picking among the 50, because everything comes back to the country at the end of the day. They're responsible for SDGs. In a country, have you selected the subnational hotspots based on inequities, geographical, ethnic, et cetera? Delivery, do we know what tools we're using? Could be a guideline, could be an innovation, could be a partnership. And are we executing? Are we tracking the results on a quarterly basis in our institution to see what's happening with that indicator? What are the barriers and how to overcome them? So in summary, I think we have an impact, a definition of impact. That's the SDGs. I think we are getting towards a definition of impact science. That's the WHO results framework with the outcomes and the outputs. But at the end of the day, we have to replace the SDGs with the GSDs. Now, has anyone looked at that blog at singerp.substack.com and can tell us what GSD stands for? It's a very technical term. It stands for get shit done, because the problem we have in global health is we've got the political commitment to the SDGs. I would argue that we've even got engagement now of young people, people around the world, et cetera. Could be better, but the engagement is there. We're starting to have discussions about the international financial architecture, but to really move the SDGs to double the pace, we need to do three things: implementation, implementation, and implementation. And that is getting shit done. Thank you very much.
Thank you very much, Peter Singer. For those who didn't know, Peter was a special advisor to the Director General, the current Director General, Tedros, and he has just left that place.
I used to say GSD stood for get stuff done, but now that I'm gone, I can say the real thing.
Thank you. Let's get to our last speaker, Fatima Suleiman. She's a very active member of AFREhealth, and she'll give us the last word here. What are her final thoughts, having heard from all this and so forth? Fatima.
Thank you, Nelson. And it's really wonderful to be among such distinguished speakers and guests as well. So good afternoon, good morning, good evening, everyone, wherever you are. For AFREhealth, the important thing right now is to assess what sort of impact we're having with our members, but also the people that our members serve. So it's a really timely conversation, because we would like to be able to see, you know, in the areas that we are involved in as an interprofessional organization, as Nelson meant before, what are we doing in terms of being able to improve quality of service, patient care, and that as an interprofessional group that do service delivery, that do academic education activities, and that we do research together in that regard as well. So, for example, I think that at the moment, for me, impact is about which point in time are you measuring? That's the first thing. Because I think Marcel also mentioned at the beginning, and others did as well, is that sometimes it takes a long time to be able to get to the actual impact you've made. But while it's easy in some of these to be able to collect the metrics of how many people have we trained as an interprofessional group to address things like HIV care and delivery, how many people have attended our webinars and have said sort of we've made a difference in terms of the way they view things, there's the other aspects that we somehow need to capture as well. So one of the smaller projects we decided to do some focus groups, and in there we learned some really interesting things. So we did this little training activity as an interprofessional group to be able to look at HIV care in different countries within the AFREhealth membership group. And in the focus group, it came out that the people actually learned about understanding where the problems are, to be able to identify those gaps in either treatment, in marginalized groups, or in terms of actual problem identification. And they started learning to do that better with other aspects in care other than HIV. And if we stick to the metrics, we don't actually understand how we then, or we don't get to these kind of stories or these kind of impact assessments that really make a difference to service delivery, to quality of care, to educational opportunities that people have suddenly learned to be able to respect other groups, work together, that is cascading down to other people learning from these as well. So there's this knock-on effect as well. So I think for me and for AFREhealth moving forward, why this is so important is how do we find impact, define impact for sure, but how do we use mixed methodologies to be able to then understand who we're reaching, how we're reaching them, how we're getting to these, and then more importantly, how do we impact not just on service and quality of life of patient, but eventually on policy making for healthcare, whether it's education, whether it's research, and whether it's on service delivery. And we do it by generating the evidence that's locally relevant on the African continent. I'll stop there. Thanks, Nelson.
Fantastic. Thank you very much, Fatima. And I should also have said that Fatima is a research professor and director of a WHO Collaborating Center for Pharmaceutical Policy and Evidence based at University of KwaZulu-Natal in South Africa. She also serves as a governing council member of AFREhealth. Having heard all this, I know we have taken longer time than we should have, but I think we needed to hear what our speakers had to say. And as we break into, or we go into a panel discussion with these same speakers and a number of funders, in this, even in the audience, Africa, we want to make a difference in Africa. AFREhealth wants to make a difference on the continent. Huge impact, whatever we shall be meaning by impact in that case. And therefore, I will not be shy to say to the funders, please help us for Africa to really survive and have the resources to do a great job. If the funders can keep that in mind and keep thinking about it, this Pan-African organization that is sticking out to do good for the entire continent, how should it be helped? Over to you, Joe. It's time for the panel discussion. And my suggestion is let's take the time that was allocated for the panel discussion. We will see where else to cut back and fit within the total 3 hours that we booked. Over to you, Joe. But thank you very much, the speakers.
I completely agree, Nelson, and that was such a rich discussion. I learned a lot, and I would like to hang on to it for a little bit. Know that we are, I think, I know a number of you are listening carefully, and we'd love to get you talking. So we are going to do a group breakout around a question for you to ponder. But let's work the panel a little bit. First of all, thank you for those who have already started to pose some questions. Professor Savada has a very thought-provoking, specific question. Dr. Keith Martin also has one that also ties in. And picking up on Keith's comment, I think what I heard in the discussion is, it does bend, impact does depend a little bit on the perspective from which somebody is coming from. Of course, there's scientific impact or research impact, and then there's health impact. And then I heard a tension in the discussion. I'm not sure I heard as many comments calling for clarity around a definition of impact as I did calling for let's have impactful research. Let's get to work, as Peter Singer had pointed out. Yeah, I guess there's some definitions that we can easily utilize there. Let's get to work. I appreciated Mosa's first comment about the fact that there's such an implementation gap. We would like to get our research projects out there making a difference in the lives of people quicker than that we are seeing right now. My first question for the panel, and also I'm hoping somebody can pick up the questions. One of the questions you see in the chat is: impact science different than implementation science? Is impact science even a science? But is there a difference there? Please, Mosa.
Yeah, thank you, Joe. So I understand more implementation science because of the intentional focus on addressing that gap on implementation. So we've invested a lot of effort in building capacity and training and learning around implementation science in order to deal with that valley of death that has to do with moving from results and policy into practice. But I think the more I engage with it is that you can do good implementation, but after you've implemented, if you are not assessing the difference you are making, if you are not demonstrating the benefit that you are seeking to benefit, then all you end up with good implementation is a good story. It's a feel-good story that those of us who get involved in implementation, we can be satisfied with at a local level. We can even draw lessons on. But it becomes really difficult to be able to demonstrate at a population level what difference we have actually made. That science that is based on real-world assessments and demonstration of impact, of the difference, the benefit that is being made, it really has to do with the impact science. When we used to do these complex interventions, we had struggle in terms of how to evaluate, and we were drawing from epidemiology. But epidemiology is best when you are in a controlled environment. We didn't really have good methods on how to count in a real world environment until we saw recent advances from econometrics that started to influence quasi-experimental studies. But now also we want to strengthen routine data. We want to strengthen registries. We want to also make sure that that base for us to be able to account for what we are doing, not only for the difference from interventions, but also to demonstrate the need for investment, to say this is the gap. We need to be able to have the ability to do that. And for me, this is what I hope impact science is trying to do. And there are people who would often talk about process and process evaluation and implementers. Then there are others who are interested in outcome and impact and measurement, and they need the platforms and the frameworks and the systems to do that well. So this is my concern, that we want to advocate for good implementation strategies, and we've got frameworks, we've got the science that is helping us to do this, but we have to do more now, also making sure that we will be able to account when the time comes for us to demonstrate the impact of what we've been investing in. I'll stop there. Thank you.
Boy, very well said, Mosa. And I certainly heard the distinction there. But I think I'm hearing a advocacy from your point of view that we should be paying attention to impact science and developing that more and being more intentional. So really good. Mustafa, did I see your hand up there, or was that maybe an up and down?
Just approve the speech of Musa, because we need to make a difference. We need to make a difference for on global health, because it's very important. The difference is impact of community health. Yes, for my view, if you want to make a difference, we need to understand community, we need to engage community. Now, it's very important. And university now, they have a big distance between university and community. In Canada, and I discover one approach with the Faculty of Medicine of the University of Laval. They try to engage community, the faculty advisory. You know, it's very important, this damage. Now, science need to engage community and to put together with community all skills for better health. Thank you. This is my opinion. Thank you very much. Thank you, Dr. Peter, to share this opportunity to take off this webinar. Thank you very much.
Oh, thank you, Mustafa. And I you know, this ties in to also comments I heard from Marie, really keeping the community and the people we're called on to serve in mind. And I have to say, when I'm in academia, I hear a lot of these same conversations that we're having right now, which is good and pushing me to think better. I know when I'm in community, or when I'm kind of trying to co-design or asking, the only two things people care about in the communities I'm in: how is this going to help me live longer or better? And obviously not everything we do is directly tied to that, but I do feel that we fail often to help people see where that connection could come. I think that's one of the huge disconnects between the ivory tower and the real world, is they just want our help in understanding how is this going to help me live longer, better? But Peter, please.
Thank you very much, Joe. And I just really wanted to underscore what Mosa was saying. You know, to your question, whether it's impact science, implementation science, it just depends which end of the stick you're picking up the stick with. And I prefer to pick up the stick, as Mosa does, from the impact end, because it's best to start at the end exactly with what you said. How is this going to extend my life? How is this going to save my life? Which SDG? You know, is it the lives of children under 5, mortality, which is an SDG, et cetera? So that's point one. Pick up the end from the, pick up the stick from the impact end, start at the end and work backwards to what you're going to do to contribute to that. Point two is, you know, that means that you're not only going to do plans, you're also going to focus on implementation. In my blog, I called for a moratorium on planning for the next 7 years, because the multilateral world is 90% plans, 10% implementation. So we also have to ask ourselves what we do less of. And we have to redress the balance between planning and implementation. I also, by the way, called for a moratorium on conferences, but I guess maybe not virtual ones talking about impact. Thirdly, I just wanted to say, you know, to what Nosa was saying, not Mosa, but Nosa, this is always situated in place and time. And so he took us to northwestern Nigeria. You know, it's the leadership, it's the country, it's the location. Imagine a world where every health minister every quarter is convening all the stakeholders in a community or a country and checking on the 5 outcomes of greatest interest: maternal mortality, HIV, et cetera, tracking it, asking what are the barriers, how do we overcome it? AFREhealth can help produce that world, and AFREhealth can help channel the research of African researchers to answer that question of how do we overcome a specific barrier that's identified. That's just a specific way of thinking about how to shift the balance from plans to implementation. And then finally, I wanted to address, if you don't mind, Joe, the question Keith asked, because I want to remind us, Keith asked about capacity, and this, of course, has been with us many years, capacity building. Just to make the link, the SDGs are only as good as the people solving them. And so it's the young people, it's the women researchers, just to really call out gender equality here in this in this session. It's the local people who understand the problems. Those are the people who are going to solve the problems. And the SDGs are only as good as the people solving them. And I think about the link to capacity building in those terms. And on my blog, the first three are actually career advice for young people. And the first element of that is find a problem and solve it. And there's no bigger problem than pick an SDG, work backwards to what you can do through an existing institution in a place and time, and go out and save some lives.
Well, thank you, Peter. And again, very vigorous activity going on in the chat room, which is perfect. We're going to have, and I also appreciate people who are using their signals when they put their hand up. There's so many of you that I can't see if you're actually trying to physically put your hand up, but if you can electronically put your hand up. Just reacting to the capacity building, I know this is an example that we use at our institution. University of Michigan, one of the things we did a long time ago is partnered with colleagues in Ghana to start an OBGYN training program. And now we've trained about 240 that are in Ghana. One has left, so a lot of people will talk about that as impact. One of the things that we haven't done, we've done a lot of research on how we did that and things like that. What we haven't done, in my mind, is take it to the next step of living longer or better. What's happened to maternal care because of that? What's happened to postpartum hemorrhage? What's happened to families that didn't lose a mother to childbirth? Boy, messy research. Attribution errors left and right. But I do think that I would like to push us at our institution to say, yeah, that sounds great. But how are people living longer or better because of that? But capacity building clearly fits in there. I wonder if we could give everybody a chance to talk a little bit by doing a breakout room exercise. And let me explain to you how this is going to work. You're going to be put into a room electronically. You don't have to do anything. But what you're going to be put into a room for is just with more of a handful of people. If you could continue this conversation, and the question I really want you to try and hang with is to say, gosh, if we're going to put more of a definition for impact than what we've talked about in a complicated conversation here, what would you offer as a definition for impact? If somebody was going to say, well, is your work impactful? What kind of answer would you want to give or offer for a definition of impact? Or would it be a rubric? So again, this is more of a chance to take the conversation down to the individual level, but this will help all of us in terms of, do we just need to have conversations like this and then go back and do good work, or do we actually need to write something down as a proposed definition of what we mean by impact? So Jenna is going to help us, and what we're going to do, again, you're going to end up in a much smaller room where everyone's going to be talking. But if one of you could plan on bringing back the message from the group to the big group, because we're going to let you do this for, let's say, 25 minutes, where you're going to talk with colleagues and others, and then you're going to come back and Nelson is going to be sampling the groups. What did this group say? What did that group say? So, and to make it more clear, you're just going to have the questions in the chat box here. So I'm going to actually type it down. Should we have more of a definition for impact? Two, what would this definition look like or read? So we're actually asking you to propose something. Or should there be a rubric or grading system, much like we looked at with the T0 to T5 scale. So those are the three questions that we hope you can bring back into the bigger group. So Jenna, can you go ahead and just divide people out and let them talk? And if you can come back with some collective wisdom for when Nelson works the group to figure out how we should move forward collectively on this question. So thanks, everyone. Stay right where you are. Jenna's going to move you, and you'll just be in a smaller group where you can all have a chance to talk. Thank you. Nelson, I think it's over to you. I think you were going to try and touch down with each of the groups to find out how they were weighing in on the three questions.
Yes, you are right. So there were 6 groups that I saw. And so each group will have opportunity to present back. And if we can be as brief as we can without losing content, that would be highly appreciated. We have 1 hour 20, about 1 hour 20 minutes left to end of the session. So we have a report back now, and then we will have, after the report back, we'll have a discussion following the report back. I think as each group reports back, we can give the audience opportunity to ask 1 or 2 questions to that group before we move on to the next group. And then when all the 6 have reported back, we will have a plenary where we discuss the whole thing together, as well as developing an impact science constructs to inform AFREhealth. And again, Joe, you'll be taking on that other discussion. So let's have group 1 reporting back. Whoever is reporting back for group 1.
Jenna, maybe you can tell us which one is group 1.
We had Candice Rodriguez, Kai McCann, Million Bimaru, and Nusa Orobaton.
Okay. So.
Hi, sorry, I didn't.
Okay, Kai.
Yeah. So I'll be reporting back for group 1. There was a couple of communication problems just in terms of, I think it's quite loud where I am. I'm in a public place, so I apologize for that. But can you hear me okay?
Yes, we can hear you.
Okay, perfect. So group 1, in terms of, should we have more of a definition for impact? We agreed that we should have more of a definition for impact. I think it was quite uncertain what everyone kind of viewed, what everyone viewed as what impact was. So like, it was kind of hard to get like a unanimous what is impact. And so following on from that, what would this definition look like or read? We said that interventions, whether positive or negative, should produce tangible outcomes, so tangible results that are directly influenced by policies. Number 3, should there be a grading system, much like we looked at with the T0 to T5 scale? We said that that was kind of very important to have, because obviously you can have a definition, but then to quantify the definition, you have to have, as you said, rubrics or grading scales. So we said that, there should be grading systems. So yeah, thank you.
Thank you very much for that. Any addition from the group? Anybody wanting to add something who was in that group? If not, is there a question from the audience for that group? Okay, I don't see any hands up. So let's go to the second group. Jenna, which group was that? Because people may not
Collins.
know that they were in group 2.
Yeah, no problem. Collins, Ankunda, Linda Caples, and Tanya Petrowski. And Peter
Hello.
Singer, who left.
Right. This is Linda Caples. I am the Director of Continuing Professional Development and a member of the Global Health Equity faculty at the Medical College of Wisconsin. And I have to actually hop off for another call shortly, but our group, basically, we surmise that, in terms of the definition and what should be included, so long as outcomes, and the objectives and the outcomes are correlated, is what's really important. We were a little leery about rubrics and grading systems without a clear understanding of how those rubrics and rating systems were going to be used, because scoring a certain score is all well and fine, but in what way, in what context, and for what purpose? Is it to help increase funding? Is it to, get a better score with the WHO or whatever? We just would want to be really, really clear on what the practice would be around rubrics and grading systems, because they shouldn't be arbitrary. And that was basically it, unless Tania, did I forget anything? Or
Let's see whether somebody was in the group thinks there's more that should have been said.
No, Dr. Caples, I think that you summarized it quite well.
Okay, so audience, do you have a question for this group? I don't see a hand up. If I'm just missing it, go ahead and speak. Whoever wants to ask a question or make a comment. No, there's no addition. Let's go on to the next group. Group
The next
3.
group,
Yes.
there was Dr. Sheku Dennis, Joseph Kolars, Mustafa Faye, and Pascal Felix.
Okay. So who is reporting back?
I'll take that one. Jen, I'm not sure if you mentioned Keith, but Keith Martin was there for a good part of it. And we had trouble hearing having the conversation mainly took place around 3 to 4 of us. But as far as the first question, definition, the majority thought that this would be something good to do. But there was an individual who wanted to make the point that, a definition isn't going to change that much. It's more intentionality about actually going to work on the things that we call impact. Question number 2 was are there ways that we could come out with a definition? And we had some discussion around elements. We pressure tested that one, people living longer and better, and one of our group participants said, well, do we even need to say living longer? Couldn't it just be living better? And then we actually did a little bit of pressure testing with a couple of people in the group about, well, let's talk about the work you do. And if people were going to live better because of that, how would we know? And at least I thought that was a fairly easy crosswalk, taking what people were doing and saying, okay, what is an impact statement for what they're doing? We didn't actually get to a group discussion on rubric or tiers. Personally, I'm attracted to rubric or tiers, but I take the point that I just heard from the previous group. It's a way of allowing people to say, for example, if we went with a definition like living better, well, maybe you don't have the evidence that people live better, but is there a policy that's now been instituted? And maybe the evidence isn't there yet that now everyone's living better because of that policy, but it's kind of an indirect surrogate measure. So personally, I think that there's some value in that, but honestly, we didn't really get into that collectively. Pascal or Mustafa or Keith, anyone in the group to add or subtract from what I said?
No, Joseph, that was a good summary. Thank you.
Thank you.
Great. So is there a question for the group? So you didn't tackle the third question of rubric as a group?
That's correct.
Okay, that's fine. All right, let's move on to group number 4.
That was Georgina Yeboah, Nelson Swenkambo, Hala, Owumugisha, Priska Adejumo, and Adili Obanjo.
Okay.
Apologies for mispronunciations.
Yes, somebody, I forget the name of the person who was going to report back. Yes, Adili.
Yes, from Kenya. So during our deliberations about the 3 questions, the first question was, should we define the word impact? And I think in our group we said yes. However, we felt maybe we need to conceptualize the term so that we make the meaning clearer. The second question, which was how the definition would look like, we felt the definition would have will include things like the influence that the projects have, the effects, the actions that the projects have. However, the effects have to be measurable. And then the last question was on grading or having a rubric for impact. And I think our group said yes. We think impact, depending on what you're doing, the effects will occur over time. And you'll want to gauge how much you are improving over time, and felt we need to have a rubric for the same. Thank you.
Thank you. Any additions from group members? No questions for them or comments for clarification? Aditi, there was a comment strongly expressed that no new definitions are required, but it is clarification of the existing definition. Do you want to say a little more about that?
Yeah, okay, yes. So during the deliberation, he said, yes, we need to define it. However, we need to be able to clarify on the term impact, or conceptualize the term impact to make it clear. I think that was the point of a bit of a discussion.
Okay. Let's go to group 5. We have 2 more groups. Group 5.
We had Dr. Kilmarks, Renee Ori, Gurpreet Rana.
Great, I can start us off. So we had actually really nice diversity, geographic and professional viewpoints in our group. So it was actually nicely captured some of the different topics and perspectives that we've been talking about. But there was among us a consensus that it would be good to have a more precise definition, better defined what impact is. But then when we got into what that definition would look like, we could see the differences in those with more of a public health focus and those with more of a scientific research or informatics focus. But we did, Renee in our group came up with a very nice, crisp definition. And Renee, if you want to go ahead and share that, I think that would be nice for all of us to hear.
Absolutely. And let me say, firstly, there's a reason why I came up with a definition, and that is for accountability, reliability, and that is necessary for building trust within the field of public health in communities and to maintain trust. So with that being said, my definition is impact is a systematic anthropological and economic measure in the field of public health that can be measured via constant monitoring and evaluation and economic gap analysis.
So thank you, Renee, and there you go. But again, that's from her really interesting perspective from the work that she's doing with refugee health, and may not cover all perspectives for those working in more on scientific research and that impact. But Gurpreet did have a good insight that what we've traditionally just looked at with impact factor and citation rates is now being also supplemented or even overtaken by the alternative metrics of mentions on social media and tweeting and retweeting and these kinds of things. And then for the third question, we actually we were a little bit unclear that one way of thinking about it is kind of is this more or less impactful, and on a 1 to 5 scale that 5 would be more impactful than 1. But then the example that was given about going from T0 to T4 or T5, you could do very high impact T1 research, you could do very high impact T5 research. So it wasn't clear if it's sort of a chronological or logical progression, or if it's a grading in terms of higher versus lower impact. So we thought it would be important to flesh that out and be clear about what we're talking about when we're talking about a rubric or a scale. That's it from me, and see if anyone else from the group wants to chime in.
Nobody from the group? Okay.
I actually do want to chime in.
Okay.
This is the thing that I believe in. You see, I do think impact, and we did mention this in the discussion, that impact in itself is a very complex and multidimensional in that aspect, and has the reason why the definition is so broad is because there are different levels that are taken into consideration, which is the research, the data, as well as the community or field impacts. And so because of that, this is why I do stress that there is accountability and reliability that has to be done, including in the research section with citations and and replicability, being able to repeat the results to show that there is an effective impact that can be replicated in various environments, and that reliability within that data is important for impact science, because if you can't replicate it, then it's not viable. Do you understand?
Okay, very good contribution. Any other comments? All right, let's go to the last group.
So I was in
Jenna?
that group to save Jenna the trouble of deciding who was there and who was not there. Thanks, Jenna. I think we had a lot of students in our group, so it was a lot about what do we mean by impact? What should the variables be in a definition rather than coming up with a definition? And it was all about, it should include the effect, the target audience and outcome, what change that occurred, the consequence of the change in that regard as well. So we were talking about what do we mean by impact, that it's not very well defined and not clear. And I think we reflected on one of the chat discussions before about the fact that impact actually doesn't appear as a keyword if you search for it as well. And then we sort of thought, in a way, about that T0 to T5 issue. And we took it the other way. We sort of looked at it in terms of a rubric where you can indicate where you're making the change. So at what level are you having an impact actually, rather than sort of using it as a rubric to kind of tick and say, this is the impact it's had. So very much to be able to say at which point in time are you having a change. And because impact is measured at a certain point in time, you might then measure, like others have been saying, again and again, and see that the impact has moved on to part of the other continuum in that T0 to T5 issue. So I think that's very quickly the summary of what we were discussing, Nelson and Joe. So I'm not too sure if anybody else in the group wants to add anything.
Any addition, please? No. Question for the group? All right, so that brings us to the reports, and some very interesting comments have really come through, and maybe as we get into the next level discussion, which will be facilitated by Joe Collars, some of the points will come through. One of those that caught my attention very much, there are many which caught my attention, but there is this one that without knowing how the rubric or the grading system will be used, it becomes tricky. And it reminded me how the people in the UK universities with this research excellence grading system, they are quick to figure out which parts of the grading system will put them in a better position so that they then can receive more money from government. And once they quickly figure that out, they would then begin to focus more on that aspect. And so you come up with the grading system, and people try to understand how is this going to be used, how is it going to affect our lives meaning the researchers, the educators, or the institutions, and then they quickly find a way. That is a behavior change which is driven by what the grading system is like. And what has been mentioned also on the definition, it looks to me that, yes, there's still work ahead to think more about this definitional issue. And the question of positive impact, and I still use the word impact in quotes because since we haven't zeroed down to what that is, that there is positive impact and there is negative impact. One of the things that came through is that impact has to be measurable, and raises the question of, if telling stories is important about impact, telling stories, there are things in stories which you can't turn into a measurable item, which raises the question, does impact have to be measurable, or is it always measurable? Or there are times when you may have a sense that is an impact, again in quotes, but it's not measurable. Those are some of the things that I picked out, but it looks like regarding question 1, should we have a definition? Yeah, I think the tendency was to say, yes, we should have a definition. Yes, we should have clarification on what we mean by impact. And the second question of what should the definition look like, that's where things, whereas the definition should be made, but what should it look like? I think that's where there was a lot of variability. And as was said, that there was quite a difference when people were talking about public health vis-a-vis some other aspects of health. Then the definition, or what the definition of impact should look like, becomes very blurred. On the question of the scale, the rubric, more needs to be discussed there on what kind of rubric, and as I said, also how this is going to be used, what are the implications, and so on and so forth. I think this is what I pick up from this report back. But if anybody else wants to make another comment, the general direction which you picked, yes, there's time to hear it. Anybody? No. Okay, so Joe, I want to hand back to you, and we continue with the plenary session, unless we have 52 minutes remaining. I'm not sure that that will be enough for going back into the groups and then reporting and having a plenary. Let's remain in the plenary, if Joe, you agree, and then you can steer us on with the discussion.
Sure. Boy, I'm learning a lot. I think this has been great insights, great feedback. I liked your summary, Nelson. And I'd like to offer maybe a summary or a reaction to what I've heard, but maybe some ideas about next steps, because that's ultimately what we'd like to do to be impactful. And I guess one of the questions that's on the table is, could this be shaped with more intentionality for something at the CUGH meeting in LA? Here's what I've heard, or maybe this is how I'm thinking now based on the discussion from this webinar. I also think a definition is useful. I take it that I understand the people who thought, this is, we need to just get on with the work. And I'm not sure a definition is going to change the need for that. I do think a definition is useful to get people actually focusing on, and I guess I'm thinking about my academic colleagues in the ivory tower, to be able to say, okay, good outcome, good p-values. I think you can do good qualitative research with stories and all, but is it impactful? Well, what definition are you using? Well, so I think something that, and just by way of background, this webinar grew out of a discussion at the AFREhealth meetings, as researchers there are trying to reflect on the collective impact of their work, and where can you put things. I liked hearing about the ingredients of a definition. Everything from as robust as Renee was offering, to a shortened version. My version is now shortened as a result of this conversation. Are people living better because of this? I do think it's a good thought exercise for people who are interested in this to try and reflect on your own work and to say, if you are impactful, what would better look like for the people? And I should put a caveat around that. Sometimes when people are thinking that way, they immediately go to what's measurable. Well, if I can't measure it, I can't articulate it. But to be able to say what's impactful here, if your work was good. I've been more impressed lately, maybe this has been there for a long time, but how PEPFAR is talking about their impact of their work. And for a long time, I heard all kinds of things coming out of PEPFAR about outcomes, but lately it's 20 million lives saved. Boy, that seems like quite an impact statement. So, and again, are they talking, is that useful for the researchers and the people who have been rolling up their sleeves? Maybe. But I think I know why they're talking that way. It's really helpful for the US taxpayer or the people who are funding this to be able to say, what are we getting out of this? So I'm still attracted to living better, and living longer often is living better. So, so I like that. The tier question or the evidence, to me, that comes down to the quality of the evidence. And you might have, so I do think that there's gradations there. Boy, Nelson couldn't be more correct in identifying we all perform to that which we're measured by. That's a fundamental human instinct. So, but I do think we would be better off as a group, and if AFREhealth could develop a research agenda that was around impact from the projects that they've been doing, that somehow lets people see how people are or could live better as a result of their work. So, Nelson, before just opening it up to suggestions or reactions, I wonder if what could flow from this. Again, this started in AFREhealth, and I assume it's going to, AFREhealth is a community of practice. How people might come together in that to say, is there a work group who is interested in working on this, and maybe developing, having good input into developing a definition and something that people could use. But I think there's enough thrust here and momentum that I think my advice would be that AFREhealth would be well advised to do this and to develop that conversation that could be maybe more widely applied or inform the world. But let me stop there and invite any reactions to my reactions or ideas about next steps, and then I can let you wrap up, Nelson, if there's no further input.
Okay, thank you very much for that. Any reactions? I can react to that, and just to kickstart. I think
Peter's got his hand up, Nelson.
Oh, where? Peter? Oh, yes, please, Peter.
The other Peter. The one who still says stuff because I still work for the government.
Yes,
so,
Peter.
Yeah,
go ahead.
This has been a great discussion, and just wanted to react to some of what Joe had been saying, and to note that the NIH has a mission statement currently that includes extending the longer life, and reducing disability, and that's actually now being re-examined, and there's a current request for information, and some of the input from the community has been about, longer life isn't necessarily better life, and so considering taking that out of the mission statement, and then about reducing disability, and that's considered by some to be a kind of an ableist statement, and discounting the lives of those who are differently abled. So that's Joe, you're touching on what's really a very current discussion within the NIH and the broader NIH community about what is really the outcomes that or the impacts that we're ultimately looking for. I do think it will be important for AFREhealth to articulate its own perspective as a real proponent of education and research, what it considers impact, and how it should assess itself and assess the work that it's promoting and supporting in Africa. So I'll look forward to really how this develops and how that perspective comes forward. I think it is nice to have this discussion about impact and to focus on impact in all of our lives, in whatever we're doing, and to think about what am I actually trying to accomplish? What at the end of the day or the end of the year do I want to see? What do I consider the impact of what I'm doing? And it could be that I've been successful in educating a lot of first graders, and what the actual long-term improvement of the society is going to be, may be a very long-term thing, but you can think about in terms of that kind of work that you're doing and what you want to accomplish, and be more intentional about that. And from my perspective at the Fogarty International Center, where we're focused on helping to strengthen research capacity and focusing on training, we've been doing this particular focus on the training and capacity building since the late 1980s with HIV/AIDS resources that became available. And I've been saying, we've trained thousands of people, and if you plant thousands of acorns over nearly 4 decades, you're going to get some mighty oaks around the world. And so we have these many success stories that we can point to, but we're trying to evolve to really have a more data and metric-driven approach to capacity, and to really be able to quantify or maybe qualify what do we consider capacity? What are we actually trying to accomplish at the end of the year or the end of a decade with the work that we're doing? So this for me is a stimulating discussion to think about, changing the discussion from just look how many people we've trained or look at this great person or that great person, to really thinking more about what is capacity, and how do we qualify it, and how do we measure success. And again, we have many success stories of this outcome and that outcome in improving health, but to really be more intentional and have metrics for it, or a rubric for it, is going to be helpful. So Thanks to Joe and Nelson for stimulating this and hosting this.
Thank you very much, Peter. Again, remarks which make one think a little more about this issue of impact. Let me pick up on one or two. The question of making people live longer. Maybe context matters, and I'm just throwing this out there. Not that it's what I feel very strongly, but maybe context matters. When I look back in this country, and I'm sure in South Africa and all these Eastern Central African countries that were badly affected by HIV 30 years ago, where people were dying in their 30s and 40s. And now, when they have lived longer because of PEPFAR, it helped those people to look after their children. The children were not becoming orphans. They looked after their children, they are in gainful employment, and their children are growing up in a family environment as opposed to what was the situation then. I'm commenting on the living longer, that maybe it depends in the context. Yes, I agree that living longer may not necessarily improve quality, but in certain contexts, as we have seen, and I see happier people in my own country who are on HIV treatment, who are happy, joyful, and no longer, depressed about, life tomorrow. The other issue is, yes, when we discuss impacts, people tend to quickly gravitate into research, but you brought out the education as well. And AFREhealth is doing not only research, it's doing education and also service delivery. And so as we think about impact and how we want to shape it and define it, whatever, we shouldn't be forgetting those other aspects other than research. Any
Nelson?
other? Yes, please.
Yeah, so I see Catherine has her hand up.
Catherine.
Thank you so much.
Yes.
Thank you. I just want to really thank you all for this discussion. And I really, I think we have a lot to learn from this group and the work that you're doing at AFREhealth. I had a specific question because I do a lot on One Health and planetary health and, the multi-sectoral working together. I think there are many lessons that we can learn from the work of AFREhealth and the context. I certainly, you mentioned that. I think it's really important. And I think, any sort of key messages or success factors that you can share on I think especially the education piece and the in-service training. I know of programs like AFREHoon and the field epidemiology training program that are really trying to bridge disciplines, and I think that's very exciting. And I think we need to also bring in the lessons from your team about what's working well, and especially how to measure impact across different disciplines. So I would love your thoughts on from a One Health lens, what can we learn? How can we engage and really just be part of this very robust movement and network? And again, just to say thank you so much for the great work.
Thank you, Catherine. This movement, and here I'm talking about AFREhealth. As I said in our opening remarks, that this is a Pan-African movement, and it is interprofessional. So it's not only for the health people, it's even the people and the vets, for example, who make a difference in the health of human beings. They are welcome to be members. And this also emphasizes or adds to the comment earlier that because we are a mixed group of people in AFREhealth, and therefore thinking about impact becomes even more important, also challenging, because of this mix of people. But One Health would fit very well. One Health people who are working in One Health would fit very well into the AFREhealth. I don't know whether my colleague Fatima is, she's still on. Fatima, what would be your comment?
So I think that, Nelson, one of the stimulating factors for getting the interprofessional collaboration going was that we very deliberately set out to have a course on HIV prevention, care, and treatment that included an interprofessional team in a case-based approach. So in a sense, it wasn't one professional that could answer this particular question. They needed the input of everyone else to work through that. And we worked very deliberately with students still studying in their sort of final year of study, but also preclinical service, so that when these groups then went out into their training thereafter, the people who they were presenting their projects to and, you know, were listening to what they were saying, were very much aware that they were asking each other across the professionals for questions and answers, and there was that respect. So I think that if you want to take this into a One Health approach, One Health, as Nelson has said, is a very interprofessional approach. It deals with lab scientists, with pharmacists, pharmacologists, medical professionals, but it also deals with things that, with people that are sales representatives, because they're doing the marketing and so forth. It deals with sort of maybe some policymakers or some funders where they deal with reimbursements and things like that. So when you're bringing all of that together, and there's WHO guidelines on AWARE that many people have not even heard about, you know, so the AWARE categories of those that are WATCH categories. So you have the reserve, the access, and you have the I forget the fourth term at the moment because it's evening here at the moment, so sorry. But what I'm trying to get to, is the fact that you need a deliberate case-based approach. You need to have people in a room or virtually or in face-to-face solving that issue, and then going out and in a real situation trying to work together to get to a problem. And once they do that, the bonds are formed and it works well thereafter. So I think that's my quick and dirty answer to your question. Thanks.
So what one can do, AFREhealth has got a website. If you check the AFREhealth website, it tells people how to become members and so on. And you are welcome to our annual symposium, which will be held in Nairobi next year. We hold annual symposia in different countries. This year it was in Maputo, or Mozambique.
So Nelson, just to say, it's normally held in August. So just look for the dates.
Okay.
It's in August. But thanks.
Okay.
Nelson,
Any other?
I saw Peter had his hand up, and then Dr. Sheku.
Peter Kilmarx again?
Yeah, I'm okay. Over to Dr. Sheku.
Okay, Dr. Shekhar.
Yes, please. Dennis Massakoy. Thank you very much, Nelson, Joseph, Peter, and everyone, including our MD, Kit Martin, for organizing this session. So sorry, I actually missed out on the breakout session. It's rush hour here. I had to dash collect the kids from school. So sorry about that.
Okay.
Moving forward, AFREhealth, basically, they are doing well. My comments, I want to drift out a bit from a statement raised by Nelson with regards to the definition of impact. Not just focusing on, say, research, education, but also the aspect of service delivery. That one actually captivated my, my mind in making this comment. Now, looking back to my own country here, Sierra Leone, now seated in my office at the 34 Military Hospital. I have been practicing general surgeon for about 10 years now at the 34 Military Hospital. So now thinking about impact, okay, due to the shortage of doctors in my country, say 3 physicians is to cater for like 100,000 doctors based on the 2020 statistics, okay? Within those 3 doctors, some are already in the ministry, you know, doing other work. So as a result, from my observation, I noticed that people coming for surgical procedures that are diabetics, to the time we invite the physician to review the case before the surgical intervention being done, there is that gap. So patients actually used to suffer. So as a result of that, I identified the aspect of closing that gap. If there could be a surgeon having found knowledge in diabetes, stepping in the gap would help to reduce the mortality that we used to have in the hospital, which was about, till last year, was about 85 to 90% mortality just from sepsis emanating from diabetes related, both from the medical ward and then the surgical ward. In the sense, when they have a case at the medical ward with, say, a diabetic foot, they request the surgeon to review that case. Because of the pressure, that's back and forth, the patients end up dying. So since I developed interest in that area, we are talking about impact, I enrolled with University of South Wales in a diabetic course. I detected that with time, the mortality from sepsis was like down. We are getting about 50%. So in the nutshell, talking about impact, as other speakers have stated, we need to like identify gaps, not just with research, good, education, yes, or service delivery. Identify loopholes, see how you can step up, and then you impact your communities. So basically, that is all for now. Thank you very much to all presenters and moderators, and of course, our Executive Director, Kit Martin, and team for putting up this wonderful session together. Thank you very much. Thank you. And that's all I have for now. Bye.
Thank you. Thank you. That really speaks to the issues that AFREhealth is trying to grapple with and challenged on how do we make a difference at the end of the day. When AFREhealth started, and from then up to now, one of the points that is frequently made there, AFREhealth should add value. What is the value add that AFREhealth is making? Because there are a number of other organizations on the continent, but what is the value add that AFREhealth is making? And was it yesterday or the day before? There was a session on global surgery. I don't know whether you attended it. It was a very nice session. And I know Keith Martin was attended, and I attended. It was a very nice session. And all that is what AFREhealth is trying to look at, but of course, limited in one way or another. And we still want to recruit more people on the continent to be part of AFREhealth. But thank you for those comments. I think we are soon coming to the end. Keith, you have your hand up. Is it?
No, I didn't, Nelson, but if I had a couple of minutes at your discretion, please let me know whenever it's possible. Thank you.
You can make your comments now.
Well, thank you, Nelson. And I want to thank you and everybody here for being on this session. Joe, thanks for co-leading it with Nelson, and Peter, great to see you, and all so many friends from Fatima and Catherine and Dr. Sheku for those powerful comments. And I just wanted to have a few things if I can share with you. You know, from our perspective at CUGH, we have a number of assets that we have, and we've been working with Nelson and Dr. Kaguli Malawadi on them. And I put them in the chat box, and they're as follows. Number one, we worked with NIH and AFREhealth to create a capacity building site, CUGHcapacitybuilding.org. Please take a look at that. Please sign up for it. Please share it, because it's a mechanism, a platform to functionally address the human resources gap that Dr. Sheku just mentioned. It's a way of bringing together training needs and trainers. The first thing. Second thing, for the funders who are out there, please invest. I'm saying this at CUGH. Please invest in AFREhealth and please invest in CUGH. But The session that you held in Maputo was absolutely inspiring. And for those of us who have been there from the beginning, and I know Peter and Joe and Fatima, obviously, and Elsie and Nelson, to see what happened in that meeting before in Nairobi, before AFREhealth was born, to what happened in Maputo was jaw-droppingly and inspiring. And I just want to say to the funders, please invest in AFREhealth. They've grown incredibly. They're an engine for change on the continent. And we at CUGH are there to learn from them and work with them to our common objectives. Finally, there are 4, if I may say, in terms of outcomes, and I put my former politician hat on, so forgive me for that. But if I put myself into the shoes of the ministers and the president's office and ask the question of how we're going to improve the kind of things we're talking about here, what that person has to deal with, of course, are 4 buckets. Do I have enough people that are trained? Do I have enough money in the pocket? Do I have the infrastructure? And can I garner the political support to actually do what I want to do? So those are the 4 big buckets. Now, they're not going to come to us to ask us that. We have to go to them. And so what I might plea to everybody who is here and our colleagues around the world is that there are amazing opportunities for academia to engage with governments, to bring them into the ground floor of what you're building, to listen to what their needs are and incorporate those needs into what you're doing. Because I think that relationship between what government's needs are and what you're doing, there's a marriage that has not happened and it has to come together. And in that, there are opportunities for outcomes, for impact, for funders. And that will do what Dr. Singer mentioned about getting shit done. So I would just encourage to look at that. And finally, just a pitch I put into the chat. There were 2 webinars we did with AFREhealth, and Dr. Siwan Kambo did a brilliant presentation on one of them, and then Dr. Elsie Malawati led the other one. Please look at those webinars we did. Please share them widely. Please engage with both our organizations and how we can do a better job in our common mission to improve the well-being of people and the world. Thank you, Nelson.
Thank you very much. And does anybody have a last comment? We should bring this to a close. Okay. If no other comment, the webinar we did, which was on South-South partnership, I think yesterday, actually, in another session, I think it was yesterday, I was called up to comment on that issue, on that webinar. And for some reason, I tried to open my mic and it didn't. But I had a question. And it relates also to this impact business. I had been listening carefully, and I had countries saying that in literally all these LMICs, they have trained people. We've been talking about education. They have trained many people, and yet there are people after that who have no jobs. So that there's a mismatch between the training and the availability of employment. And of course, in Uganda, I've been hearing that all the time. But in that particular session, it hit me hard. And I said, if this is, let's say, across Africa, this is happening all across Africa, how can we work together to actually bring this attention to the heads of states summit, to the African Union, so that maybe that way movement could happen. I wrote it down in my book, and I said, moving forward, I am going to find a way, talking to colleagues in AFREhealth, on how we work on the issue. document the gaps in different countries, how many people are floating out there on the street, so to speak, who are not in employment, or people who have left what they were trained for. Not that you'll always be stuck in what you are trained for, but they left what they trained, not because they wanted to leave, but because there were no opportunities. And if we can get that information from many countries across Africa, I think it will be powerful finding. And now you get into the impact. So what if you produce this and share it with the heads of states? What impact are you going to measure or to assess afterwards? I just got an opportunity to say what I was going to say when I was asked to do so in yesterday's session. So coming to the end.
Nelson, can I add to that before you disappear? I think we
do.
also need to look at when you're collecting that information, the kind of training platforms that exist as well, because I think that within Africa, we're losing the opportunity to combine public and private sector infrastructure to be able to absorb these additional people and do training. So I just wanted to add that I think we need to relook at how we incorporate this sort of excess workload, because obviously governments have a limited budget for human resources, but the private sector can also absorb them and train them, and there should be some public-private partnership to allow this kind of exchange of staff and skills development. Sorry, I'll stop there.
You see, there is already one person agreeing that we should move in this direction. But let me try to bring this to a close. So moving forward, I think we've made a very good start on the discussion of this issue of impact. And we are beginning to create, I think, people who are interested in this subject matter, and more discussions, but of course with action at the end of the day, instead of just discussion. And therefore, forming a community of practice, I think, would be the wise thing to do. In AFREhealth, we have different groups looking at different issues. Yesterday, again, there was a session on climate change and health, and our president was coordinating or facilitating that discussion, indicated that we will be forming a group on that. I think we should form one, even on impact, to move the work forward. And the momentum should really build up. There is the CUGH 2024 meeting in Los Angeles, and I think there would be a good place to continue this discussion, take it to another level, so that we are not just repeating ourselves from what has happened today. We will have to find some resources to make that happen. I didn't get opportunity to check on, the deadlines for submitting application for holding either half-day meeting or workshop on such a topic, but we'll find out. I hope there's still time and we are not too late. So that is the community of practice and participation at CUGH, and we would love many people from the African continent to participate in that. So whether we'll make it a hybrid, face-to-face and online, to really maximize contribution is something we need to think through. And then there is the AFREhealth Symposium in August, which we talked about, usually it's in August, which we talked about earlier. Actually, it has been advertised already, and it is for August. We should continue again with the discussion on this issue. For me, as I thought yesterday and day before, thought some more about this session, I started to say, we are going to do an impact evaluation study. We had planned to do one because we were asked by the governing council. These kind of questions, we should have put them into consideration. And maybe moving forward, we may go back and have some reflections on some of these issues, and they might impact how we do the study that we talked about. That is, if we are not too late to cause some change in that direction. That's how I'm summarizing this, and let me thank all of you who have stayed up to this time to continue into these discussions. Thank you very much. Thank you, CUGH and your staff, to Keith Martin and your staff for supporting this meeting. Jenna and her colleagues have been very active in this, and thank you very much. Of course, there are many people who are on this, who logged in and were here in the first hours. Even though they have left, we thank them for having attended. I think the proceedings of this will be, Keith, what happens to the proceedings of these meetings?
Thank you, Nelson. Yes, this meeting is recorded. It will be shared on our website, given to AFREhealth. We will share it with our 30,000 network. When you receive it, please share widely, and that way we can share the wisdom that you have given to all of us. And just to pick up on Nelson, please do come to our meeting in Los Angeles. Let's have a workshop on this topic, and I hope that we'd love to be able to, if acceptable to AFREhealth, continue this in Nairobi. And thank you, Nelson, for your leadership in bringing us together. We're really grateful as always.
Joe Collas was very instrumental in bringing these ideas of questioning impact because he's a member of our advisory board for the NIH grant that is supporting AFREhealth. And so he really planted the seed of questioning impact. And here we are, we grabbed the opportunity and we are ready to take it forward. Thank you very much, colleagues. We will meet, I hope, even before LA, because we should continue communicating and laying a strategy for that meeting. Have a nice day, evening. Some of you some people might actually be well into the night already. Thank you and bye-bye.
Great work, Nelson. Thank you.
Bye.
Thank you. Bye-bye.
Thank you, everybody. Thank you so much.
Bye-bye.